In this video, we're going to talk about local control within the lung that adjusts airflow to specific regions of the lung and blood flow to those same regions. And the general term for that local control is called ventilation-perfusion matching, right? So ventilation referring VA is the symbol. Ventilation referring to the airflow to particular regions of the lung, and perfusion referring to blood flow. And if you'll recall, we use Q as our symbol for flow, right? And we want those to match. And when they do match, as we've seen before, right, we've given this sort of generic, like if this is an alveolus, right, and we end up with, ventilation. We haven't talked much about the mechanisms of getting gases. We've talked about breathing, the mechanism of breathing, but the gases diffuse in and out of the alveolus, largely because they slow down as you move into this blind-ended bag. But the point here is that, what I'm trying to make here is that we end up with a PO2 at the alveolus of about 100. Right? We've talked about that before. We use that value, and the beauty of that value is that our hemoglobin ends up being 100% saturated at that PO2, right? So despite it falling because we are tidal breathers, we talked about that previously, right? There's a mixing of fresh air with air at the lung, already in the lung and at the lung surface. The partial pressure of oxygen is lower than atmospheric PO2, which is about 160, right? And again, we talked about that when we discussed Dalton's law. But okay, so we're breathing to maintain this alveolar pressure that's sufficient for saturation of the hemoglobin in the adjacent pulmonary capillaries, which I have not shown here. Now, we said that this is 100. It is, and that's true. When you're laying down, every region of your lung is probably about 100. When you are vertical, there's a gravitational effect. Pulmonary blood pressure is really low. And so at the top of your lung, the blood flow is low relative to the airflow, and you end up with this high ventilation to perfusion ratio, right? You end up with very well ventilated very well ventilated region of the lung, but very small portion of the blood flow out of that region because of the gravitational effects. Whereas if you go to the bottom of the lung, right, the blood tends to flow downhill. Remember the heart's kind of in the middle of the lungs, right? The pulmonary pressures are low, and so the downhill flow to the bottom of the lung is much better. Well, that tends to compress the alveoli a little bit. The ventilation there is still very good, but now the blood flow is much higher. And so we end up getting two different, three, if you will, middle, top, and bottom, sort of a gradation of PO2s in those regions of the lung when we're vertical. Okay? So, and again, that's because of this sort of mismatch, this gravitational effect that causes a mismatch between the perfusion and the ventilation. But overall, it ends up being about 1-to-1. Again, because it's, ventilation is high and perfusion is low at the top of the lung and vice versa at the bottom of the lung. And so if you sort of average it all together, you end up with this sort of 1-to-1 ratio. Okay, great. But that means we're not like optimizing all regions of the lung. And so is there a mechanism of sort of like trying to push against this mismatch of ventilation and perfusion that occurs just because of gravity? And the answer is yes, right? And so we have to look at, let's look at our anatomical picture over here, right? We've got our arteriole here, right? So this is our blood flow coming into, right? This would be the pulmonary. And honestly, let me adjust that, right? Because if it's an arteriole and it's pulmonary, it's carrying deoxygenated blood, right? Remember, the venous blood, right, would be carrying blood flow out away from the lung surface, the respiratory membrane surface, and would be well oxygenated, or much better oxygenated, right? So let's make sure we have our colors right there for oxygenated and deoxygenated. And so, but the point here is that we've got our arteriolar blood flow coming in, and then we've got our airflow coming in through the bronchioles, right? Here's our bronchiole, right, branching, and I'll put a different color on here. Airflow can be designated by purple, if you will, if you like. Right, so this is airflow, right? And so we've got airflow adjacent to our blood flow, right? And this is we need our ventilation to match, or as closely as possible, match our perfusion. We can't overcome the gravitational effects, but the body's trying to sort of maximize this one-to-one relationship. And what we need to see, here's the short end of the story here, is that we have control at two locations, right? We have smooth muscle that surrounds the arterioles before the capillary beds, and we have smooth muscle that surrounds the bronchioles before the alveolar sacs, if you will, where those clusters of alveoli are at the very distal lung. And so what we're going to find is that we have essentially the exact opposite effect on blood vessels relative to oxygenation. Okay, so bear with me here. Let's think about your big toe or your spleen or any other systemic organ, right? If that tissue becomes hypoxic, if it's low in oxygen, what would you want to do to blood flow? Would you want to send more blood flow or less blood flow if there's not enough oxygen there? Hopefully the logical answer is you want to send more. And so hypoxia would induce vasodilation, right? In other words, the vessel would open up, the arteriole would relax, we would send more blood flow and more oxygen to alleviate that hypoxia. Now come back over to the lung. If there's a region that is hypoxic in the lung, you have to think about what the purpose of blood flow is to the lung, right? It's not to deliver oxygen, it's to pick up oxygen. So when a region becomes hypoxic and there's not enough oxygen, let's go over to the right here, right? We've got the same thing over here, except we've got our smooth muscle doing something different, right? But if we have poor ventilation over here on the right, we have low oxygen. Look at what the arteriolar muscle is doing, right? The arteriolar muscle is constricted. Number one, it's going to match, if you will, right? It's going to match the blood flow to the airflow. But again, the area is hypoxic. And so unlike the systemic tissues that would cause vasodilation to deliver more oxygen, the rationale here is, well, there's no oxygen to get, or there's very little oxygen to pick up. So let's reduce the blood flow here and send it, look over here, right? This is well ventilated, right? We have good O2 here. And so this is dilated, right? Arteriolar dilation, send more blood flow where there's good oxygen, right? Because remember the purpose here, the objective here, right? The adaptive purpose is to get more oxygen into the bloodstream, right? And that happens when we have more blood flow where there's good airflow. Now, having said that, does it make sense if this is really well ventilated, right? We may want, in other words, if we can't actually send enough blood flow here, what we may want to do is actually constrict this a bit, right? And sort of like shunt the airflow from here over to some of that airflow over to here, right? By changing the resistance. Because again, we want all regions of the lung to sort of be optimally ventilated and perfused. And so we get this sort of bouncing back and forth. The areas that are well ventilated and well perfused will shunt away to other areas, if you will, right? Because we're optimized here, right? It's fantastic. And not that we want to reduce that, but we want to sort of share the wealth, right? Where we want to send some of this ventilation to other areas. Because remember, if we can have the more vessels we have perfusing well ventilated areas, the more oxygen we can get, right? And so we don't want, you can't have just really good ventilation and perfusion at one spot and be like, okay, that's good, right? Well, you need all of them to work optimally. And so to do that, we get the smooth muscle, so the 2 points of control, right? The arteriolar smooth muscle helps us regulate the blood flow to these regions. The bronchiolar smooth muscle helps us regulate the airflow adjacent to that blood flow. And we want the two to match. And the rationale, again, for this matching is that we're going to have neural control of total lung ventilation, right? But because of this gravitational effect that I was talking about when I was talking over here, right? When I was talking about this PO2 not being 100 in all regions of the lung, means that we've got to try to compensate for that difference as best we can through this ventilation perfusion matching, right? Locally controlling, and again, think autocrine and paracrine, mostly paracrine, regulation, local chemical, control. In other words, the high, let's go over here. The low PO2 here is going to, and the high CO2 here, again, for the same reason, poor ventilation, would cause constriction of this arteriolar smooth muscle, right? And vice versa on the other side here, right? We would, where we have good ventilation, we would want the arteriole to be open and give us matching good perfusion. Okay, that's local control of airflow and blood flow, and we'll do another video on neural control of breathing.